Hey everyone, I'm Professor Thomas Seaton, your instructor for Respiratory 100. This video is about standard precautions, not what they are exactly, but why they exist and why they matter specifically for you as a future respiratory therapist. Before standard precautions were established, infection control in healthcare was reactive. You'd look at a patient's chart, see a diagnosis, and decide whether to take precautions based on what was already known. The problem, people can be infectious before anyone knows it. HIV, hepatitis B, and hepatitis C, these were the disease drivers behind the original guidelines. Healthcare workers were getting infected, and in many cases, nobody knew the exposure had happened until it was too late. Standard precautions were the answer to that problem. The core assumption flipped. Instead of asking, does this patient have something, you treat every patient, every time, as a potential source of infection. Blood, body fluid, mucous membranes, non-intact skin, all of it every time, regardless of diagnosis. Now, in respiratory therapy, standard precautions aren't just relevant, they're critical. Here's why. We work in airways. That means we are, by definition, working in the highest risk zone for respiratory pathogens. We're suctioning, we're intubating, managing ventilators, performing breathing treatments. If a patient has an airborne or droplet transmitted illness, and sometimes we don't know that yet, we are the clinician closest to the source. So think about a patient presenting with a cough and a low O2 saturation. Influenza, could be TB, could be nothing contagious at all. You don't always have time to wait for the workups. Standard precautions means you're already protected before you walk in the door. This is the part I really want you to hear. Standard precautions only work if they become habit. Not, I'll glove up when I think I need to, not this patient seems fine. Every time. Consistent practice. The reason compliance matters is twofold. First, you protect yourself. Healthcare workers have a real occupational exposure risk, and a needle stick or mucous membrane splash can have serious consequences. Second, you protect your patients. Patients in the hospital are often immunocompromised. They're already fighting something. You bringing a pathogen from room 4 into room 7 is a real risk if hand hygiene breaks down. Standard precautions protect both directions. That's part of why they exist. As you move through this module, you're going to look at the specific components of standard precautions. Hand hygiene, PPE selection, respiratory hygiene, safe injection practices. Each one of those connects back to what we just talked about. When you're deciding which PPE to put on, you're making a clinical judgment based on anticipated exposure. When you're doing hand hygiene before and after patient contact, you're breaking the chain of infection. It's not bureaucratic compliance, it's applied infection control logic. You'll start to see how this builds. We'll get into transmission-based precautions later in the module, contact, droplet, airborne, and those layers on top of standard precautions, not instead of them. So why standard precautions? Because we can't always see the risk. Because the cost of a break in technique is real for you and your patients. And because good clinicians build these habits early before they're stressed, before they're tired, before they're in a code at 2 a.m. Build the habits now. That's what this module is about. And I'll see the rest of the content. Reach out in my inbox if you have any questions.